to the next speaker, Professor Chiribiri. He's professor of cardiovascular imaging in UK, and he will present us the CMR qualitative and quantitative approach. Professor
Yes,
Chiribiri.
Good morning, everyone. Thank you so much for the introduction, and it has been very nice listening to the previous talk. And Professor Nivert gave us a very good information about, how much different information we can get from a CMR for a differential diagnosis, and actually, amongst the tools which have recently established themselves in the guidelines, we also have dynamic perfusion imaging, which if you look at the current guidelines, is effectively accepted as a class 1 with a high level of evidence A indication, and that for the detection of ischemia. That applies to both the current European guidelines and the US guidelines. And that's the novelty, as you probably have heard before. Nuclear medicine is very strong in the United States, but cardiac MR is increasingly being used, and for very good reasons. Now, Professor Mavrogheni, which I would like to thank for the invitation to present today, has asked me to discuss both visual assessment and quantitative analysis. And therefore, I would like to just show you this picture, which summarizes both methods. So you have on the top your T1 weighted images, first pass perfusion images. These are dynamic scans. I'm showing you the peak enhancement image where perfusion defects are more evident. Grayscale images, which are T1 weighted, dynamic, and acquired during the first pass of an injection of a contrast agent. And we do this twice during the scan, during adenosine or regadenoson or dipyridamole stress, so a vasodilatory stress scan, followed by rest injection in baseline conditions. And some centers are actually skipping the second injection. Now, if you look at the images on the top row, you will have an apical image, a mid-ventricular image, and a basal image. And what the arrows indicate are the presence of areas where perfusion is delayed. So blood and the gadolinium, which is contained in the blood, is reaching the myocardium slower than the surrounding areas. So effectively, what you have are islands of hypoperfused myocardium in hyperemic conditions, which can be clearly seen as separate from the surrounding regions of normal perfused myocardium, which have much brighter signal. Now, there are a few things that we can say about this specific example, which kind of summarize why stress perfusion CMR is becoming so popular. First of all is the high spatial resolution of the acquisition. In this case, images were acquired around 2 millimeters in plane resolution, which is higher than any nuclear medicine method, with a coverage of all the 16 segments of the standard AHA model. Second, you see that we do have enough in-plane resolution on stress perfusion CMR to visualize the very essence of ischemia in the myocardium. That is the fact that ischemia is more severe in the endocardial layers. In fact, you can appreciate the gradient of perfusion from a relatively normally perfused myocardium in the epicardial layers. So let's use as an example in the basal slice the inferior wall, that's the RCA territory. So there's a rim of normally perfused myocardium, but as the compressive forces in the microcirculation increase, moving towards the inner layers, then perfusion is impaired. And then a second parameter, which is very relevant, is the fact that stress perfusion CMR, thanks to the fact that it uses a vasodilatory stimulation, is not limited to the identification of the most severely diseased area in the myocardium. So clearly here we have a very large perfusion defect in the RCA territory, but we can also visualize a much more tenuous perfusion defect in the LAD territory that's pointed by the red arrow here. And I think that's the main advantage of stress perfusion CMR compared with stress echo, which is instead relying on administration of high-dose dobutamine stress. in that we can actually provide a stratification of ischemia across the 3 coronary arteries, and we do not have to stop the stress when the first and more severe, more evident perfusion defect appears. Now, this is visual assessment, what we had just performed. So we are looking visually for areas of perfusion defects, and instead quantification is summarized by the lower images. And you have bullseyes at stress, rest, and myocardial perfusion reserve bullseyes. Effectively, in this kind of representation, you have an outer ring, which represents the basal slice, a mid-ring, mid-slice, and an inner ring, which represents the apical slice. And if things are done correctly, you will identify ischemia on a still image, in this case, as areas of reduced perfusion, which are color encoded, in this case with the purple area to indicate ischemia, an orange area to identify normal myocardium on stress and NPR images. And you can nicely see in this patient a very large area of ischemia in the RCI territory, which affects the inferior wall and extends partially to the inferolateral wall. And also you can nicely see, and that's marked by the asterisk, the correspondence of the to the visual images in terms of mild but definitely present ischemia in the LAD territory. So it is a very good method to make an objective measurement of myocardial perfusion. So why do we want to use quantitative perfusion as opposed to visual assessment? Why is it really proposed by the experts as the next step in the chapter of ischemia imaging with MRI? Well, because we know from details published in the literature that visual assessment is not quite as sensitive for ischemia as quantitative analysis. In this pivotal study from Amit Patel and colleagues, published in 2010, we had the first hint. See that if you subject to a stress perfusion scan patients with either a single vessel disease CAD in blue or 3 vessel disease CAD in yellow, visual analysis, which is here called qualitative interpretation, does not really differentiate the ischemic burden in the myocardium. It is very accurate in identifying patients with ischemia, but when it comes to detecting the true burden of ischemia across the entire myocardium, there is no real difference. And one of the reasons which have been proposed for this finding is that effectively the human eye, when we interpret visually the images, is effectively relying on identifying normally perfused areas to use as a reference, and then refer to the abnormally perfused areas as those which are less perfused than the normal. And if you have patients with 3 vessel disease, where most of the myocardium is abnormal, at least some of the less severely diseased myocardium, even if it's still ischemic, are sometimes called normal as a reference, so become the reference. And therefore, we are not very good at calling global perfusion defects. And instead, if we use perfusion reserve analysis, or MPR, which is stress over rest as a ratio of quantitative analysis, in the same study, the authors were able to demonstrate for the first time that quantification actually has an advantage and is clearly able to differentiate single vessel from 3 vessel disease. So quantification is objective. It is more sensitive for diffuse ischemia. So these are the first 2 take-home messages. Now, what are we getting wrong with visual assessment? Well, I think we have a summary in this slide. This is a patient with some coronary artery disease. I'm showing you the same image 3 times in 3 columns, where you do have 3 different levels of windowing of the images. So we've picked different levels of grayscale. So we go from a very soft contrast, mid contrast, and very high contrast. And at the bottom, you have the peak image, peak enhancement image of each series. So based on the level of grayscale, we can move from a very specific diagnosis, where we only pick up LAD disease. So we give away a little bit of our sensitivity to be more specific, and that will be a single vessel disease. And if we go all the way to the right, we'll still have perfusion defect in the LAD territory, but there will also be a perfusion delay in the lateral wall. So effectively, just based on changes in the grayscale level, in this case, we could change diagnosis completely from a single vessel disease to a two vessel disease. And that, of course, comes with some potential implications in terms of the management of patients. So I would say that that's probably the main limitation of visual assessment. And look what happens in the intermediate windowing level. You can clearly see a severe perfusion defect in the LAD, like on the other images. And then depending on how sensitive you are, how trained you are, you may or may not detect the perfusion delay in the circumflex artery and report it or not. So that's actually left to the expertise of the reader. So a big limitation of visual assessment. Limitation is that, of course, cardiac MR is increasingly used. Scanners are nowadays capable of acquiring cardiac MRI, no matter whether they're installed in cardiology or in radiology, whether they are in a large hospital or in a small diagnostic center. So there is a real need, real demand to increase the number of scans. These are numbers from 2019, 2020 from a British Society of Cardiac MR survey, indicating that, for instance, in the UK, there are more than 115,000 scans. There were more than 115,000 scans performed, and there were 84 active units at the time. We now estimate a number well below 130, with definitely around 200,000 scans. So there is an increase in demand, and this cannot be matched by a number of trained doctors to report all the scans. So in a way, we need to start thinking how we simplify the analysis of the images so we make it quicker for doctors to come up with a diagnosis. And actually, look, if I'm showing you the map of the UK, and I bet this applies across the board to other European countries, you see that there is a huge variability in the service provision of cardiac MRI. It's exactly because expert readers tend to be more easy to find in the London area. In fact, in London, we perform a lot of these 200,000 scans a year, about half of it. And then and that applies to approximately 12% of the UK population, 50% of the scans, and the other 88% has access to the other 50%. So there's a huge disparity in delivery. Now, we know that stress perfusion CMR is a complex type of images to read. It takes actually quite a few hundred scans reported in, double reported with a level 3 expert to become equally experts. And we have published a few years ago a study to correlate, testing the correlation between the level of training and the diagnostic accuracy. You see that if you are level 2 accredited, that's the minimum to report independently, you will be as accurate as a SPECT scan in detecting ischemia, that is around 66%. And if you want to be as good as the CMR study has suggested that CMR can be, that's 84-85% accurate, then you need to be level 3. And I would say level 3 plus. Our level 3 readers in this study are really academic level 3 readers. But look what happens if we throw quantification in the mix. We can have a fully quantitative method, which is at least as accurate as a level 3 reader in identifying ischemia. So really the proposition here is that if we can make quantitative analysis completely automated, we can actually simplify the job of our colleagues, which are working perhaps in smaller centers or have not reached the level of expertise to be super accurate, and actually guide them through the process and simplify the diagnosis to the benefit of the patient. So how does perfusion quantification work? Well, many of you will be familiar with the concept of the central volume principle, where effectively the task is to measure the amount of blood flowing through a vascular territory. And we do this by injecting an indicator at the inlet of the vascular territory. Just consider this the input of the inlet of the coronary arteries. And then we measure the concentration of the indicator downstream. And then we use clever mathematical operations to relate the two and come up with quantitative perfusion measurements. Effectively, if you're using this methodology in the cath lab, you will be able to simply divide the concentration of the indicator at the point of injection and the concentration of the indicator at the point of sampling, and that will create a ratio, which is the dilution ratio of your indicator, and then multiply that by the speed of injection of the indicator from your syringe, and that will give you the flow. And that's the way in the cath lab how we measure the QPQS invasively, for instance, in patients with congenital heart disease. Now, when it comes to MRI, we can apply the same principle to the MRI images. The complexity is given by the fact that in MRI, we are injecting the tracer in the peripheral vasculature, usually in the antecubital vein of the arm. And therefore, the mathematical operations that we have to use to extract the quantitative information are different. However, and they're much more complex, but they can be simplified to the following equation, which says that F, that's the flow we want to measure, equals the vascular volume in the coronary arteries, including the microcirculation and the epicardial vessels, divided by the mean transit time of the contrast agent across the vascular compartment. And mean transit time is effectively a probability density function which tells you how long it will take on average to a particle to 50% of the particles injected or the tracer injected to leave the vascular compartment during washout. So effectively, we are focusing on the washout phase. And this can be nicely visualized by the first mathematical representations of this phenomenon, which were actually just on a theoretical basis. I'm referring to these patients, paper published in 1962 without any patients being scanned, just based on the mathematics, where Zierler was hypothesizing a full injection of tracer in the coronary arteries, which is signaled by this Dirac delta function, so vertical function, followed by an exponential monodecay, which can be measured and used to calculate the mean transit time. So it is something that it's very difficult to reproduce in practice. You can imagine as a mental experiment where if you want to measure a water flow of a tap, you can put a glass full of orange juice under the tap and see how quickly the orange juice gets washed out. And if you, assuming that you had a method to calculate the concentration of orange juice, that exponential monodecay of the orange juice in the glass would tell you how much water is being wasted through the tap. So it actually, if you reproduce that in the lab, it works. It doesn't necessarily work very well in patients because, as I said before, we're not injecting the contrast agent as a bolus in the coronary arteries, but we're injecting it in the periphery. And therefore, our first pass of the contrast agent doesn't look like a Dirac delta function. It looks more like a two-bell-shaped input function. And that's this tall curve here with its recirculation. And the myocardial response looks like a single pass equation. So if you have this kind of curves, then in order to reconstruct the relationship between input and output in an exponential form, you can actually apply an operation that you will find cited in the literature at every corner, but is also something that creates quite a bit of confusion. And this operation is called deconvolution. So deconvolution is a way to normalize the myocardial signal by the shape of the input function, so that it doesn't really matter which shape the input function has, can be an arbitrarily shaped input function, but the relationship of the deconvolution operations will always be a mono-exponential decay. From that mono-exponential decay, we can start our vascular modeling and we can calculate the flow. And don't worry, I'll show you in a minute that this is all done automatically. So apart from understanding the main principle of the operation, there's nothing else you have to do to obtain the values. Now, in terms of quantification, the methods of acquisition are actually, something that you can achieve with pretty much all the scanners. We have been simplifying them over the years. So nowadays, we have very clever acquisition protocols which allow us, after basic planning of the sequence and injection of adenosine, to have a sequence which contains all the ingredients to cook these perfusion maps. You need a proton density scan to normalize the signal intensities. That's embedded in the sequence, so you know, this is going to happen automatically. You don't have to plan it or do anything about it. You will need a dual sequence acquisition to correct for the saturation of the signal. And dual sequences is effectively a sequence that there's an additional slice in the acquisition, which is hidden from your sight, from your view, which acquires the input function with a different T1 sensitivity to prevent saturation effects. This kind of image can be hidden, so you don't have to worry about it, or can be displayed by some of the softwares. So if you want to post-process it or keep quality control, you can still do it. It really depends on the solution that you're using for quantitative analysis. And then all you have to do is inject the adenosine. At 3 minutes, you inject the gadolinium, acquire the scan, and in very few seconds, you will get the maps directly represented on the scan. And how does the acquisition look like? Well, we have an example here. So that's an example of our dual sequence, which works on Philips and Siemens scanners at the moment. And it's available for any one of you that would be interested in starting this quantitative analysis in your local center. So just get in touch with me and we can discuss how we can install it. So this is an example acquired at 3 Tesla. 3 Tesla is a great scanner for perfusion because it has a little bit more signal to noise and really gives us high resolution images. We can still work at 1.5 if required, not a problem. But 3 Tesla is the best scanner for this kind of applications. You see that we have a myocardial slice. That's the top image. That's 1 millimeter in plane resolution, completely motion corrected. So the patient is actually free breathing in this acquisition, but the motion gets taken away in the reconstruction. And at the bottom, you have your dual sequence input function, which gives you the input data for the vascular model. And I would like to show you how good the motion compensation can be. This is a patient which we scanned a few years back, a gentleman, 61-year-old, who had a previous balloon-only angioplasty in Sri Lanka, and then moved to the UK and had chest pain episodes. And the patient didn't speak any English and was unable to follow our respiratory commands. You see that CD images is highly contaminated by motion due to the respiration. However, this is how his perfusion images look like acquired in free breathing. And you have the stress images at the top and the rest images at the bottom. And if we play the movie, you see that the respiratory motion is completely removed. And therefore, the myocardium is in a fixed position. And therefore, that allows a pixel-wise mapping without any motion being included in the maps, which is instead something which is still affecting T1 mapping, where due to the inversion recovery pulse used for the acquisition of MOLDI sequences, if there is any respiratory motion in there, it's much more complex to motion correct. Instead, we now master this in perfusion. And then less than 90 seconds after the acquisition of the images is over, and this is an example on our Siemens scanners, you get the quantitative maps directly calculated on the system and displayed on the scanning interface. And a very frequently asked question is, commonly asked question is whether you need to install additional hardware to obtain this. Well, the answer is no. This is a software update. Any current Siemens scanner can do this without installing any extra computers, which actually makes it so much easier to deploy. Certainly, there are other solutions which require installation of computers like Gadgetron, but we realize that installing additional hardware, which is not FDA approved, and giving access to third parties on hospital networks is not necessarily the thing you want to do with your scanner. or something that the IT service of the hospital will allow you to do. And that's why we have designed this solution in collaboration with Siemens. And as I've said, since we worked a lot with Philips as well, and this is all something similar is available on our Philips scanners as well. And I know for sure that there's a fact that also General Electric is working on a solution. So rest assured that quantitative analysis is actually coming to the scanner and is going to be available for you to use. Now, a couple of additional information which might be useful. In the future, we won't be limited to 3 slices for perfusion imaging. If you talk with your nuclear medicine colleagues, they will point quite correctly that stress perfusion CMR is only sampling the myocardium over 3 slices. Actually, we can do more. We can do 6 or 9 slices using technology called simultaneous multi-slice or SMS perfusion. This is something which we have published on already a few years ago, and we are working on a product which, like in this case, will allow you to cover 6 slices in this example, having all your quantitative perfusion maps calculated in line. Now, is this important? Yes, it is, because the current CMR guidelines prescribe to plan your slices position as 3 slices of 5 over a systolic frame. And that frequently results in having 3 mid-myocardial slices, like this, and this, or mid to apical, and to neglect the base of the heart. And just to remind you, at the base of the heart is vascularized by the left circumflex artery. Sometimes there is just that ring around the mitral valve, which is vascularized by the circumflex. And if you do not cover that region of the myocardium, you might miss ischemia in this territory. So having a proper coverage of the basal slices is really essential. The other take-home message is that quantitative perfusion MR is completely automated, and that's made possible mainly by the deployment of artificial intelligence modules directly on the scanners. That's again something that we have pioneered with our main scanner partner, Siemens, where you do not need to have external hardware or you don't need to connect your computer to Amazon Cloud and send your patient's data to the cloud in order to get a model or high resolution reconstruction and quantification to be performed. You can do all of these automatically on the system. And AI is actually involved in a number of steps, such as detection of the position of the heart, temporal filtering, the detection of the arrival time, and the modeling of perfusion itself. And of course, myocardial segmentation. Quantitative perfusion CMR has a strong prognostic value. And it has a stronger reclassification capability than visual assessment. That goes very well with the fact that we can see more multivessel disease, as shown by previous studies. And there are a number of clinical studies which confirm the prognostic value of the methodology, even when Fermi function is not utilized as the main deconvolution method. And out there are a lot of publications which are now coming out on the clinical validation in patients with microvascular disease, multivessel disease, coronary artery bypass, cardiomyopathies like hypertrophic cardiomyopathy, DCM, or pediatric population, where we also headed the charge. And just to conclude my talk, I would like to show you that just a few weeks ago, the SCMR has published on the Journal of Cardiovascular Magnetic Resonance, the SCMR Expert Consensus Statement on Quantitative Myocardial Perfusion, CMR. And that's the key document that I'm pointing your attention towards, as it contains a detailed guidance how these measurements should be performed, what is the quality assessment that needs to be carried out, and how the images should be interpreted clinically. And I would like to conclude, that's my last slide, showing you in one slide how CMR perfusion, stress perfusion with quantitative mapping can guide us in the management. So you have here an example of a normal myocardium with orange, nice perfusion, very homogeneous everywhere, so normal perfusion values. And you have an example of a patient with 2-vessel CAD. So again, severe ischemia in the RCA territory, that's the inferior wall, and some inducible ischemia in the anteroseptum, which depend in this patient from a plaque shift from the LAD, otherwise treated with stenting. Then you have a patient with 3-vessel disease, coronary artery disease, and previous bypass. See, there are patches of severe perfusion everywhere. And then, very importantly, and that's something that I'd be happy to take on in the discussion, if of interest, microvascular disease. Quantitative analysis can diagnose microvascular disease. Can do that showing you a concentric ring of subendocardial diffuse mild ischemia throughout the myocardium. And this pattern is completely different from 3-vessel disease and CAD. So I really think that with this method, high resolution quantitative perfusion mapping, we can finally diagnose those forms of INOCA or ANOCA, which are dependent on the primary disease of the myocardium. So thank you so much for the attention, and thank you, Professor Mavrogheni and organizing committee for the invitation. And if there are any questions, of course, please ask. Thank you.
Thank you very much, Professor Chiribiri. It was an excellent presentation. Thank you for sharing your knowledge about quantitative assessment of perfusion. There is one question. Is a 3 Tesla suitable only for quantitative perfusion or for all sequences?
No, 3 Tesla is, well, that's the interesting story, interesting question. So I worked the first time with the 3 Tesla scanner back in 2007. And at the time, we couldn't complete the scan. We couldn't get good images reliably. We had problems mainly with late enhancement and a little bit with CME images as well. But then very rapidly, vendors came up with improved shimming, improved hardware. And nowadays, there are very few indications where 3 Tesla cannot be used. One example, T2 star mapping of the heart and liver. You know, we don't have reference values for 3 Tesla, so you should really use a 1.5 Tesla system. On the other side, the other indications are doable at 3 Tesla. There are now some indications which are better at 1.5 Tesla. So for instance, if you have a patient with a pacemaker that is conditional at both field strengths, 1.5 Tesla will give you less artifacts. But if the device is conditional for 3 Tesla, you can probably scan the patient at 3 Tesla as well and deal with slightly less good image quality. On the other side, for 3D late enhancement, for 4D flow measurements, for perfusion, 3 Tesla is superior. And for scene imaging and flows and T2 stirs, you know, it's about the same. So, you know, like, so if you ask me whether you should buy a 1.5 Tesla system, I would say probably due to costs and siting requirements, start with the 1.5 Tesla, but make sure that your second magnet is a 3 Tesla.
Mm-hmm. Can I ask you, actually, you use adenosine as a stressor. Of course, that's reasonable to assess perfusion, but could you use, for example, dobutamine to have also the wall motion assessment together with perfusion? Is it feasible?
Yes, unfortunately, we are very limited in the use of dobutamine for perfusion imaging. And the main reason is due to the fact that we have a target heart rate to reach. So we need to drive the heart to very high heart rates so fast that acquisition becomes very challenging. Just consider that stress perfusion is a real-time technique. So we must be able to acquire one image for every geometry, every heartbeat. But we can only do this reliably up to 110 beats per minute. And above that, we start missing beats. And just imagine a young patient where your target heart rate is maybe 180 beats per minute. Then in that stage, you will probably miss every other heartbeat with a very fast cardiac output, meaning that you probably will not get enough information to either perform visual or quantitative analysis. So that's a limitation. On the other side, since the onset of regional wall motion abnormalities is the most frequent reason to interrupt a dobutamine stress apart, of course, from having completed a normal scan, then the risk is always that you will always stop to a suboptimal level of stress for the second most severe vessel, and that's a concern.
Professor Chiribiri, can I ask you a question about AI in evaluation of single multivessel disease or microvascular disease? Which one do you think that you expect AI to help you increase the accuracy?
So I think AI is already helping us in generating these beautiful maps that I've shown here, because just consider the first software which I have written for quantitative analysis, which was very primitive, right? So I'm a cardiologist with minimal knowledge of programming, yet we had to prove that this was feasible clinically. But this software had about 200 parameters that you could interact with, and it was, of course, like a research test bed. AI makes this completely unsupervised, so completely objective, and that's already a great step forward. And then I think what AI can do is give you a probability of disease, and therefore can tell you, I think that this is rather normal, or might be a single vessel disease, or might be microvascular disease. This is a new era, so there are no data out there, but we're moving towards a situation where AI can actually help in the interpretation of the maps. With one caveat, though, that if we had a system which, told you the diagnosis, that would become probably a class 3 medical device, because it would inform automatically therapeutic decisions. And as such, vendors are not particularly keen on implementing this technology, because that's the kind of technology that you find in cardiac valves, for instance, right? So it's much more difficult to prove that the solution is safe. So there might be a delay in deploying these systems to users. But, with AI, almost everything is possible if you have the right data.
Thank you very much. There are no other questions as I see. So thank you again, Professor. And we move on to the next